ISTM is pleased to present this online educational webinar entitled From Jungle to Departure Gate, Complex Yellow Fever Scenarios in Travel Health. And I might add, this is just a very popular webinar. There are over 900 registrants, so a lot of us out there. I hope things go well. The webinar is organized by the Professional Education Committee and the Nurse Professional Group at ISTM. And the planning chairs include myself, Darvin Scott Smith, and Tara Lombardo, and Dr. Aisha Khatib, and Dr. Yen Bui. And a special thanks to our sponsor, Sanofi, that helped provide the program. It's our pleasure to introduce today's moderator, Tara Lombardo. Tara?
Thank you, Scott. Well, it's a big pleasure to be here with all of you today to discuss this very important topic. We have quite an impressive panel of experts today, but I just want to say for the full bios for each of the speakers, please see the ISTM website. So our first speaker today is Bhawani Kankar. She has 18 years of experience in travel medicine. She currently works at the Seawalk Hospital Travel Medicine Center as a clinical research nurse and in-charge nurse, vaccine in-charge nurse. She's earned her certificate in travel health from the ISTM in 2016. Bhawani currently serves as the co-chair alongside myself with the nursing professional group. She is also on the steering council member of the ISTM examination committee and the ISTM mentoring task force. She has significant experience in travel diarrhea research spanning over a decade and managing frostbite cases. She has a special interest in immunizations. Our next speaker is Catherine Keil. She's an Australian-British nurse practitioner specializing in travel health and immunizations with a clinical experience across the UK, Africa, the Middle East, and Australia. She's helped establish the travel health clinic for the Emirates airline in Dubai and holds the ISTM certificate in travel health, a diploma in travel medicine, and a master's in nursing. Catherine is the former chair of the ISTM Professional Nursing Group and a fellow of the Faculty of Travel Medicine, Australian College of Tropical Medicine. Our next speaker, Shelia Seed. Dr. Shelia Seed is a chair of the Department of Pharmacy Practice at Massachusetts College of Pharmacy and Health Sciences University, and has been a faculty member since 2001. She has extensive experience in public health, immunizations, and travel medicine. She holds the ISTM certificate in travel health and is an associate faculty member of the travel medicine at the Royal College of Physicians and Surgeons in Glasgow. In addition to teaching, she provides pre-travel consultations in a primary care setting and currently serves as chair-elect of the ISTM Pharmacist Professional Group. Our next speaker will be Dr. Albert Schumacher, is a family physician with over 40 years of clinical experience in Windsor, Ontario, practicing within an 18-member family health organization. He's a graduate of the University of Western Ontario and has served as the president of both the Ontario Medical Association and the Canadian Medical Association. His work includes significant contributions to public health, patient safety, including board roles with the Canadian Patient Safety Institute and the Canadian Medical Protective Association. In addition to teaching medical trainees, he is also a partner of the Travel Health Windsor Clinic, providing vaccinations, travel advice, and testing services. And our final speaker for today will be Linda Boss. She's a clinical coordinator for ambulatory care at the University of Michigan Health West, where she leads standardization of care, patient safety initiatives, and program implementation across ambulatory services. She provides pre-travel consultations and delivers travel health education to medical learners and professional audiences, including national nursing conferences. Linda is board certified in ambulatory care nursing, holds an ISTM certificate in travel health, and serves on the ISTM nursing professional group. So we'd like to begin our discussion with our first speaker, Bhawani. Thank you.
Namaste everyone. Greetings from Kathmandu, Nepal. Thank you, Tara, for the introduction. And I'd like to thank ISTM and Sanofi for organizing this webinar on yellow fever. I have no conflict of interest. Today I'll talk about yellow fever, its epidemiological updates, and brief refresher on WHO CDC guidance. Let's get started with an overview of yellow fever. Yellow fever virus is a single-stranded RNA virus that belongs to the genus Flavivirus. Aedes, Haemococcus, and Savethis species are the main vectors. The transmission of yellow fever virus occurs via the bite of an infected mosquito. Non-human primates and humans are the main reservoirs of the virus, and anthropootic transmission can occur. In Africa, yellow fever virus has three transmission cycles. They are jungle, intermediate, and urban. The jungle cycle involves transmission of virus between monkeys and mosquito species found in the forest. The virus is transmitted by mosquitoes from monkeys to humans when humans are visiting or working in the jungle. Intermediate cycle involves transmission of yellow fever virus from tree-hole breeding Aedes species to humans in jungle border areas. The urban cycle involves transmission of virus between humans and peri-domestic Aedes aegypti. In South America, yellow fever virus has only two transmission cycles. They are jungle and urban. Moving forward to the geographic distribution, yellow fever occurs in sub-Saharan Africa and tropical South America. In areas of Africa where there is ongoing circulation of yellow fever virus, natural immunity gets built up with age. Therefore, infants and children are at greatest risk of disease. In South America, yellow fever occurs most frequently in unimmunized young adults who are exposed to mosquito vectors through their work in forested area. In West Africa, yellow fever virus transmission increases during the middle of the rainy season, that is around August, and peaks during the early dry season, that is October. In East Africa, the season for yellow fever virus transmission is same as West Africa, but it is generally less predictable because long years often pass between virus activity in this region. In South America, risk is greatest during the rainy season from January to May, with a peak incidence during February and March. Aedes aegypti can transmit yellow fever virus in both rural and urban areas even during dry season. The risk of acquiring yellow fever for travelers is difficult to predict. The given numbers are the estimated risk for illness and death due to yellow fever for an unvaccinated traveler visiting an endemic area for 2 weeks. There are 29 African countries with risk of yellow fever virus transmission. Only some parts of the country has risk of yellow fever virus transmission for the 7 countries marked with asterisks. Among the 13 countries in South America, the 9 countries marked with asterisks have risk of yellow fever virus transmission to humans in only some parts of the country. Let's move on to the epidemiological updates. Costa Rica reported a confirmed yellow fever case in an American traveler who recently visited Peru before traveling to Costa Rica. This table shows the number of confirmed yellow fever cases and deaths in the 6 countries of South America during 2024 and 2025. Colombia has the highest number of cases and deaths, followed by Brazil. Only Ecuador had no cases in 2024. All the cases are of 2025. This table breaks the number of cases in 2024 and 2025. We can clearly see there is a threefold increase in 2025 compared to 2024. This is a series of maps with yellow fever cases in South America. Left-hand side map is of 2023, the middle map is of 2024, and the map on the right-hand side is of 2025. Here we can see the yellow fever cases are increasing every year. Back in 2024, in the middle map, the cases were mainly concentrated in the Amazon region, but in 2025, it has begun to spread outside the Amazon region. For example, Sao Paulo state of Brazil and Tolima department of Colombia. These places have recorded cases. This map is from Disease Outbreak News from WHO. In Africa, from October 2023 to February 2024, 8 countries have reported active yellow fever transmission with confirmed yellow fever cases. There was a huge outbreak in Angola and Democratic Republic of Congo back in 2016 and in Nigeria in 2017. We can obtain the current outbreaks information from these different sites. Let's move on to WHO CDC guidance regarding yellow fever vaccine recommendation. WHO recommends the yellow fever vaccine to be given at age 9 to 12 months at the same time as the measles vaccine in yellow fever endemic countries. To prevent yellow fever, all countries at risk must achieve high vaccine coverage through routine immunization services. As per CDC, yellow fever vaccine is recommended for all travelers aged 9 months and above visiting areas with yellow fever virus transmission. According to WHO, a single dose provides lifelong immunity and no booster dose is needed. However, CDC says a one-time booster is recommended for certain circumstances. Linda will be explaining more about this later on. This link includes only countries or areas where WHO has determined there is a risk of yellow fever transmission and where there are country requirements for travelers, and this was last updated in January 2023. This map of Africa shows the countries where yellow fever vaccine is recommended. Similarly, yellow fever vaccine recommended countries in South America. Let's move on to the final slide about yellow fever vaccine. YFVax and Stamaril are yellow fever vaccines from Sanofi. Both are live attenuated vaccine with virus strain 17D. These two vaccines are used all over the world. However, Brazil, Russia, and African countries use different yellow fever vaccine. Immunity develops in within 10 days of vaccination for 80 to 100% of people. So validity begins 10 days after the date of vaccination and it remains lifelong. This is all from my side. Thank you for listening to me. Hope to see you all in ISTM 20. Namaste.
Thank you, Bhawani. That was a really great presentation. Our next presentation will be Catherine Keil on the reluctant elder.
Hello, and thank you for allowing me to discuss yellow fever in the reluctant elder traveller today. Apologies, this is a recorded presentation, but I am based in Australia. I have no conflicts of interest in regards to this presentation. So during the next 10 minutes, I will be discussing balancing the yellow fever risk in older adults. So let's look at risk through a case study. So we have a 71-year-old male traveling to South America. He's going to Chile and Peru and Cusco and Amazon in the Peru for a total of 6 weeks. He's allergic to penicillin and he's got a history of hypertension. He's on nifedipine and he's leaving in 2 weeks. He's staying in hotels and mainly doing tours. So what are your thoughts? Personally, I would prefer to have more information about his itinerary. For example, where in the Amazon is he traveling to and for how long? We need to assess risk from the yellow fever virus. And throughout the next few slides, I'm really going to concentrate on his age of 71 years. So we need to firstly understand the epidemiology and risk from yellow fever virus. We need to know up-to-date country and area specific risk for yellow fever. What resources are we going to use? What resources did you use in your clinical setting? Now, this is just an example of a resource that I use. This is Shelia and Travex, and it highlights the yellow fever risk areas in Peru. So a busy slide, but just to summarize, what is the risk from yellow fever virus for this 71-year-old traveller? We obviously need to be aware of the following information: travel destination, the intensity of yellow fever transmission in the area they're going to visit. Are there any current outbreaks? The season of travel, the duration of travel, how long are they traveling in a yellow fever area for? Their activities allowing exposure to mosquitoes, and their immunization status. Has this traveller been vaccinated against yellow fever before? As we are probably aware of this information from CDC, I will just go through it again. Risk is obviously less in South America for yellow fever because mosquitoes in the forest canopy involved in the transmission cycle in monkeys only rarely come into contact with humans. So there are also in South America a higher level of vaccination coverage and hence immunity in local community, which reduces the risk of transmission. Risk is approximately 10 times higher for travel to West Africa. And obviously, risk is much higher during active outbreaks. And earlier this year, the US CDC issued a level 2 travel notice, practice enhanced precautions about yellow fever in South America due to a rise in cases and spread to newly affected areas of Bolivia, Colombia, and Peru. Also, the Pan American Health Organization warned earlier this year of growing yellow fever activity in South America. In the first 3 months of 2025, there was 131 human cases of yellow fever confirmed with 53 deaths. In all of 2024, there was 61 cases reported and 30 fatalities. Now let's look at the yellow fever vaccination generally. So all currently manufactured vaccines contain the live attenuated virus. A single injection induces a broad spectrum of immune response within 10 days in 95% of individuals. And protective levels of antibodies is 80% plus within 10 days and 99% within 28 days. Now, yellow fever vaccination is administered for 2 purposes: to prevent the international spread of yellow fever by protecting countries from the risk of importing or spreading the virus. These are requirements established by the country, and to protect the individual traveller who may be exposed to yellow fever infection. So now let's come back to the elder traveller. Now this slide is from the ISTM and shows the contraindications and precautions of the yellow fever vaccine. I would like to highlight there is a precaution to the yellow fever vaccine in any traveller 60 years or older. Not a contraindication, but a precaution. And this is due to an increased risk of an adverse syndrome in the older traveller due to their aging of their immune system. So yellow fever vaccine associated neurological disease increases to 2.2 per 100,000 doses in people aged 60 years or older. And yellow fever vaccine associated vixotropic disease increases to 1.2 per 100,000 doses for age 60 years or older. So this reaction is similar to yellow fever disease. So there's a higher risk generally from the vaccine. Now, because of the risk for serious adverse events after yellow fever vaccinations, as highlighted on this slide, practitioners should consider the contraindications and precautions of the vaccines. We need to use available resources and ensure we have adequate training before administering this vaccine. So as highlighted in the previous slides, age of 60 years of older is a precaution for the yellow fever vaccine. You need to consider the risk and benefits of vaccinating older travellers against yellow fever for the first time. We need to inform and gain informed consent. Now, these are extremely useful tools in decision making, the next few slides, and these are available by the CDC, an interesting flowchart showing what to do in the relation to precautions of the yellow fever vaccination. And further resources, again, from the CDC. It may be a bit difficult to see exact wording. It's all, the references are at the end of my presentation. But again, interesting reading to ensure we give the correct advice. And again, a valuable resource for contraindications. So as we are aware, the international health regulation permit countries to require proof of yellow fever vaccination documented on an international certificate of vaccination as a condition of entry for travellers arriving from certain countries to prevent yellow fever virus importation and transmission to destination countries. We also have medical exemption letters or waivers, and this may be indicated if the vaccination is contraindicated for medical reasons, particularly indicated where medical contraindications to yellow fever virus, and they're not actually entering an endemic zone, but require certification to fulfill international health regulations alone. Now, medical exemption certificates or waivers can be written on basis of age alone, but there is a need to be careful in regards to this, and there's the fact that there's no actual risk of disease associated with the itinerary. So now let's look back at our case study, our 71-year-old traveller. I just get the information up there. We need an exact itinerary to ascertain risk from yellow fever. We need to review vaccination history to see if they're vaccinated prior. We need to go through their medical history. We need an informed discussion with the traveller on risk from the yellow fever virus v risk from the vaccine. We need to ascertain if there's any further planned travel to a yellow fever area in the future. And we need to adhere to state, territory, and national guidelines. Now, I just want to take this moment to generally discuss scope of practice. We need to ensure wherever we're practicing in the world that we're following our scope of practice for our state, territory, or national guidelines. In Australia, we follow the national guidelines for yellow fever vaccination centres and providers. A little bit of information there. And these are just my references. So a very brief discussion on the elderly traveller on yellow fever. I do encourage anybody interested in this topic to do further reading and further training. Some resources are listed here. And thank you for listening.
I just want to thank Catherine. Unfortunately, she was unable to be with us today. Our next speaker is Shelia Siege on the family dilemma.
Hello, everybody, and thank you for attending. Today, we're going to talk about the family dilemma, as we often get in our clinic. We have families come as one appointment. So today, we're going to have a family presenting for a pre-travel consultation, and they have an upcoming trip to Ghana so they can attend a funeral. They've never been to Ghana before, and they'll be staying with relatives while they're visiting. They'll be leaving in 14 days and plan to be in both rural and urban areas surrounding Accra for a period of 1 month. And they'll be leaving on December 25th and then returning on January 25th. So our family consists of mom, who is a healthy 26-year-old female. She's currently breastfeeding her 8-month-old infant. She's up to date in all her childhood immunizations. She received Tdap during her recent pregnancy, but she's not received her influenza vaccine for the season, nor has she ever received the yellow fever vaccine. And she's just currently taking prenatal vitamins. Dad is healthy. He's up to date in all his childhood immunizations, but his last tetanus diphtheria was 11 years ago, and he too has not received his influenza vaccine, nor has he ever received the yellow fever vaccine. Has no health conditions and is not on any medications. The son is an 8-month-old. He weighs 9 kilos, and he's up to date for his age, for his childhood immunizations, and he has not received his influenza as well. So today we're going to talk about what are the considerations for yellow fever for each member of that family. So a little bit about Ghana. It's considered yellow fever endemic. They enforce very strict public health policies requiring proof of yellow fever immunity for entry. So that's for anybody ages 9 months and older. You must present with a valid international certificate of vaccination or prophylaxis, commonly known as the yellow card. To the customs agents when they come in, or you have a valid medical waiver. So when we're considering this family, we need to look at the contraindications and precautions and their risks. So we're looking at they're at not only in the urban areas, but they're also in the rural areas, so that may be putting them at a higher risk. And travel obviously is unavoidable because they're going for a funeral. The Ghanaian embassy states that they will accept a medical waiver for infants less than 9 months of age and for breastfeeding women. But with that, we also need to make sure that we give them the inset precaution education if they're not going to be vaccinated. So we'll start off with the mom. So yellow fever vaccine in breastfeeding mothers is not an absolute contraindication. It's a precaution. So generally the CDC says, avoid it if you're breastfeeding in general. But if we can't avoid travel or we can't postpone the travel, then we need to evaluate the risks versus the benefits if they're traveling to an endemic area. So we are having this patient go to a rural area, which could be at high risk. So we need to evaluate whether we can do this or not. If we could give her the vaccine, and I probably would. Oops. We also have to tell her some education. So she would have to temporarily cease breastfeeding for 2 weeks post-vaccination. If we had known before she was coming, we could tell her ahead of time to pump and store her breast milk for the child. She could freeze that for quite a long time. But because we've only seen her now 14 days ahead of time, we need to tell her that once she gets vaccinated, she needs to continue pumping her milk and discarding that. And that has to be done for the full 2 weeks. So she still has to maintain her hydration to continue to maintain the milk supply for the 2 weeks that she's not breastfeeding. So it's important that she has that education that she has to pump and dump, as we say. But she also needs to maintain that hydration so she can actually continue to make the milk. So when she's asked that 2 weeks, she can actually continue to breastfeed her child. Dad is the easiest one in this case. It's straightforward. He has no contraindications. He has no precautions. It's mandatory for everyone aged 9 months and older. So he will get a yellow fever vaccine at this visit. And as I said, stated before, that we have to fill out the yellow book for him, and he needs to have that with him. We always tell our patients, put that with your passport, because if you lose it, you're either denied entry or they're going to vaccinate you at the airport. And I think I would rather take my chances with being vaccinated at home. So Ghana also requires that the vaccine must be administered at a minimum 10 days prior to travel. So we're at 14 days out, so we really don't have a whole lot of wiggle room as far as waiting to have them decide whether they want the vaccine or not. 8-month-old, we could go a couple of different ways. It's usually not recommended for children under the age of 9 months, as Catherine had just stated. It's a precaution. This is where we would do the risks versus the benefits, because children under age 9 months, we have that encephalitis risk, particularly for children that are younger than 6 months of age. You're not going to give that. And also, if mom is exclusively breastfeeding and it's a child that's under the age of 1 month, they don't recommend the vaccine at all because they have been cases of encephalitis. So it's typically reserved for those that have unavoidable travel to an endemic area. So we're having this case where he's going to be staying with family, he's going to an endemic area, they're going to be in rural areas. So this is a particularly high risk area. You could also consult with a pediatric travel health person that may be able to guide you in which way to go. It's a healthy child. You may decide to do this, but if you don't, you must have a waiver, and we tend to put a lot of stamps. I think the customs agents like stamps, so we put our yellow fever clinic stamp number on that. We put the physicians, I work with a physician, he puts his stamp on it and has a wet signature for any waivers that we give to our patients when they're traveling to a yellow fever endemic area and that they're asking for a waiver. But we also must educate about strict mosquito bite prevention. We need to make sure that the parents understand that they need to wear like long sleeves and preventing with using DEET repellent, using insect net bedding. So it would be avoiding any kind of mosquito biting between those peak hours, so that dusk to dawn. We also want to make sure that we tell our caregivers, just not just mom and dad, but the relatives too, that they really should be monitoring for any illness that the child may be seeing. So if they're having kind of a fever or they're looking a little fussy, maybe we should be looking at, maybe they need to be evaluated if they have not been vaccinated. As we say, we have a captive audience when they're in our clinic, so we like to look at all their vaccinations. So we would look at the hepatitis A if they're not immunized, typhoid, meningococcal is season and area dependent. But we could also consider giving the MMR to our infant. He hasn't had that yet. So if we give the yellow fever vaccine, we're going to give the MMR at the same time because we don't have enough time for the 28-day separation. Influenza, both mom and dad could get their influenza vaccine. The child would only be able to get one. He would need another one in another month. They also have to consider the malaria prophylaxis. And we again stress the mosquito bite prevention with repellents and bed netting. And also the traveler's diarrhea, any kind of medication that would be needed to avoid that. And these are my references.
Thank you very much, Sheila, for that excellent presentation. Our next presenter is Dr. Albert Schumacher with the immunocompromised traveler.
Thank you very much, Tara. Good morning, everyone. I'm going to tell you my practical ways of approaching these travelers and what I would generally do with these cases, and some of the implications of actually diagnosing someone or putting them into the category of being immune compromised. Because that's often the tricky part. And once we do say someone's immune compromised, there's some extra obligation. Okay, so today we're going to have a practical approach. This is not a substitution for taking the time to do, for example, the CDC trainer course. And much of my advice is based upon 42 years of lots of vaccination experience. Okay, so this is a gentleman I recently had in my office, actually several weeks ago. He's a 74-year-old widowed 2 years ago. He has no kids, and he started to travel a lot to make up for it. Last winter, he took a 6-month cruise, pretty much around the world, but it did not really include any stops in yellow fever areas. This year is going to be different because the cruise ship is actually going up into the Amazon for 5 days. And he was told by the cruise ship line he needs to specifically be yellow fever vaccinated and have a certificate or be exempted. He has absolutely no chronic medical conditions. In fact, he was recently at his doctor's and told he was doing great. He walks 5 kilometers every day when he's in country with his daughter's dogs. He wears a weighted vest. And he has told me that he signed up for each and every excursion while he is in the jungle. So he is going to get his hands and feet dirty, so to speak. So what would I generally do with someone like him? We'll take the next slide. I would vaccinate him, yes. Okay. He really only has age as a risk factor. Okay. And I'm going to talk about what the relative importance of that age is for risk in some subsequent slides. He is somebody who travels extensively. If he doesn't need the yellow fever vaccine now or for just these 5 days, he certainly will in the future based on the kind of things that he's doing. And looking him over, I mean, this man is tanned in November. He doesn't wear long sleeves. He doesn't seem to do a lot of sun protection. And by inference, he's not going to be very good with the precautions that we generally give him, including mosquito repellent and nets and hats and other stuff. Yellow fever has certainly been on the rise in South America in the last years, has been alluded to. And he's also not somebody who is otherwise very willing to be vaccinated. The only other thing I could convince this gentleman to get was typhoid vaccine. And this is somebody who is going on a cruise ship where, the incidence of acquiring influenza seems to be 5% of the total shipload per week. All right, so let's go to the second case. And this is Letitia, who came in with a history of a kidney transplant. So she's traveling to Ecuador in February, and she is spending 3 nights in the Amazon, not previously yellow fever vaccinated. The donor kidney came from her sister in 2017, and her diagnosis with Berger's disease, which was an IgA nephropathy. So it has worked very well since there was some familiar genetic sympathy, we'll call it. She's taking an anti-rejection medication once a day. It has not changed since her surgery. She has no real other chronic medical conditions. Her sister is going on the trip as well. And it makes you wonder, is the sister at somewhat greater risk because she has only one kidney? But the answer to that is truthfully no. And she's a good historian, and that'll come to be important in a second, okay? So what did I do with her? Did I vaccinate her? No, because she is definitely immunosuppressed or immunocompromised, okay? Did I advise her to go into the yellow fever area? I said, or advised her not to go? I said, yeah, I advised her not to go into the yellow fever area because we couldn't really protect her. Is she going anyway? Yes. Did I further review the anti-mosquito precautions and netting and DEET and long sleeves? Yes, I went over all of that twice. But now we're in the situation where I have actually diagnosed someone with immunosuppression, okay? And now the obligation's on me to review all of the vaccinations with her, okay? Because this is something that's generally not well done by the people who are using biologics or the people who are doing transplants. It's much better done, with people doing elective splenectomies. I mean, every hospital has a protocol and list of all kinds of things that you need to do before you can take somebody's spleen out. I mean, they need meningitis vaccine, they need Haemophilus influenza B, and the list goes on and on. There are protocols. And there are not the same protocols in place with immunosuppression by biologics or methotrexate, or in the case of transplants, at least not that I have seen well that are utilized. Okay. So what did I actually find? Because this is where I said she's a good historian. Let's look at the next slide. Um, Pre-transplant 2017, she had not received pneumococcal vaccination, which was quite surprising because, we had at the time Prevnar 13 around, Pneumo 23 was around as well, and she did not receive either of those. And then subsequent to the transplant, she had not received conjugated 20 vaccine Prevnar 20 or Capvaxive 21. And by the way, in our province in Canada, Prevnar 20 would be covered under the provincial plan for somebody high risk under the age of 65. It's covered for everybody over 65, but this person is high risk that would have been covered. She's not had a COVID booster in either of the last 2 years. She did have influenza, but not COVID. And nobody had bothered to give her RSV vaccine either, even though it has been covered since it came out 2 years ago by the Ontario Renal Program for people both on dialysis or transplant. So these were 3 vaccines that I was now going backwards to give her, okay, because of this immunocompromised situation, because we know that these people are 10 times as likely to be hospitalized. They are 10 times as likely to die if they get any of these infections. All right, let's go to a little science. Okay, what do I ask people when they come in to cover all of these things? Because, from the charts that we've seen, it looks like you could take an hour to figure out, should I or shouldn't I? So what I ask people is, have they had any transplants before? Okay, that's probably the easiest one. Have they ever had a blood cancer? Because specifically, if you have a leukemia, any aplastic anemia, those kind of things, there will be a lifelong contraindication to getting live vaccines. Lots of people now have other cancers. So, have they ever had or will they be having chemotherapy or radiotherapy? Because we want to avoid giving a live vaccine during the time when they are immune suppressed from either of those things. And generally, we would want to wait until at least 3 months afterwards. And then, do they have an autoimmune disease? Okay. And autoimmune diseases by themselves are somewhat immunosuppressing or immunocompromising. And then many of these people are going to be on a biologic or a suppressive drug, which will make them immunocompromised. Okay, so that would include methotrexate at 20 milligrams or more a week, prednisone at more than 20 milligrams a day. Now, for the poor historians, one of the ways to help sort that out, and I look up the drug with them, each and every time. Okay, so I show them and we can make sure, but I ask them, did they have a TB skin test before they started whatever drug we're talking about? Because sometimes that's the only way that you're going to twig that out of them on history. You also want to know, are they HIV positive or do they have AIDS? And if so, what is their T cell count? And what was referred to previously is there is an absolute contraindication to vaccination with a live vaccine if the T cell count is under 200. And there is a relative concern or precaution if they are between 200 and 500. And if they are more than 500, you're absolutely good to go. Most people who have HIV readily know what that last number is. Okay, I would say 95% of people have that on the tip of their tongue. And then the final thing is I see if they know how to spell thymus, if they've ever had any kind of medical disorder or tumor or surgery involving their thymus. So those are my questions, and it kind of if we scan all of those things, it will usually help us screen out most of those things, in addition to looking at people's medication list. If you can move on to the next slide. Now, the other place that you can get caught, and this is a place that we are going to get caught more often, okay, lately, because we've been having measles outbreaks all over the world, including in my county. So public health had asked us back in the spring to give second MMR shots to everybody 29 to 55. So we've had lots of people who will have had this very recently within the last 30 days. And we'll also have a lot of primary care doctors who, hear that they're traveling somewhere and go, oh, measles, and we should give you a shot. And they may have had a shot within the last month, okay? Same thing with kids under 5 years of age. We were ordered to give early MMRs to those as soon as 13 months old or a month after their first dose. Nasal influenza vaccine is still being used in many provinces in my country and elsewhere. That's a live vaccine and would require us to wait 30 days. And people are getting monkeypox and chikungunya vaccine that may have been given elsewhere. Remember, they may be coming to you second because your clinic has a yellow fever license and ability to issue certificates. So you may be the second stop, and they may have had some of these elsewhere, the monkeypox at public health, in my county's case, or chikungunya from another provider, especially with the outbreaks that are going on around the world, including in places like Cuba right now, where I'm getting lots of phone calls from people about, can they be vaccinated and should they be vaccinated? All right, let's move on to the next slide. Okay, so this was alluded to previously, okay? Does being over 60 mean that somebody is immunocompromised, okay? And no, it's not. But there is a fourfold increase in serious adverse events, including deaths, for people over 60 compared to under 60. Now, if remember that 1.2 per 100,000 number includes everybody. That includes well people and the people who have several chronic comorbidities. So let's help sort this out in our minds. So when we're looking at somebody from across the desk or across the table, what do we do? If we look currently at risks from respiratory infections, because we've now looked back since COVID at all of the other things that present us with hospitalizations. So, RSV, influenza, COVID, pneumococcal. Generally, being over 65 increases your risk of hospitalization or admission to the ICU or death by about 2.5 times. Diabetes 3 times, coronary artery disease 3 times, COPD 4 times, and being immunocompromised, like on a biologic, 10 times. Okay, and these risks are additive. So if we have a 65-year-old who also has diabetes and has COPD, then that person would probably have, in terms of respiratory infections, the same mortality and morbidity rate as someone who is immune compromised. So who do we look at not giving the vaccine if my 74-year-old previously was not just 74, but if they were diabetic and they had COPD and they were on several puffers for that, that would have changed my mind about immunizing them, because collectively these other diseases have added to their decreased immune function. And so in that case, with several comorbidities, I would have probably not vaccinated the 74-year-old and given them a waiver certificate. And probably the 74-year-old with COPD and diabetes wouldn't be signing up for every tour in the jungle. Okay, and my final slide is to tell you that the expectation, or at least what's happening in our clinic, is we are our population is under-vaccinated. In Canada, only 3% of people are up to date on everything that NACI, which is our equivalent of ACIP in the States, and probably for many of you, what your national recommendations are for vaccines. So, your travelers are likely not any different. So, in other words, I am giving as many domestic vaccines in the course of a consult and visit as I am travel vaccines that people are paying for. And then when we get to those immune compromised people, you need to look especially carefully to make sure that all of those things are up to date, because being immunocompromised puts them into the highest risk group for every vaccination that you can probably spell and know. And we need to be much better and much more aggressive ahead of time, and getting our specialty colleagues ahead of time, if they're not doing it themselves, to send them to people like us to make that happen. And with that, my final slide, I will thank you very much, and I look forward to your questions.
Thank you very much, Dr. Schumacher. A great presentation. It's always a difficult situation with that population. So our final speaker is Linda Boss on the one-dose debate.
Okay, everyone. So my section is on what do we do with the traveler who has received a yellow fever vaccine and they are coming to you 10 years out for travel advice. What do we do with this traveler, and do they need a second dose? So for my section outlined, we are going to talk about two things: the history and timeline of yellow fever vaccine, and also some case studies involving the revaccination of yellow fever in travelers. Next slide. So in yellow fever, the history is early understanding. In my early days of being a travel health provider, if a person had a yellow fever vaccine greater than 10 years previous, we would give them another dose. It was understood that protection and immunity was 10 years. However, with the shift in evidence in the early 2000s, that they realized a single dose provides 95 to 99% immunity for people within 30 days. So given this data, the WHO made the decision in 2014 that they no longer needed to have a dose after 10 years, and that a one dose would be sufficient for life in an immunocompetent person. And in 2015, the CDC also adopted this, that a single dose is adequate for most travelers. And we are going to be talking about what traveler might be clinically indicated to have an additional dose after 10 years. Now, this being said, there are countries have the authority in their own health departments to say, for our population, we are going to require that if a yellow fever dose is greater than 10 years, that we will require that for our travelers and our population. I did some research. I don't see that any countries are requiring that currently, but that is something that you need to be mindful of when you are giving travel advice. Next slide. So there was something that I added this slide because as a clinician in a family practice setting here at University of Michigan, we do titers all the time. We do titers for mumps, rubella, measles, hepatitis B, anti-surface antibodies. So I was wondering if there is the ability to have an objective measurement if a person had immunity against yellow fever vaccine. Why aren't we doing that? So the number one reason we do not is because yellow fever is known to provide long-term immunity, often for life. Also, globally, it's not cost-effective or practical to implement a widespread immunity testing, and there are some incidents of false positives and false negatives. And also, with our immunity, antibody testing does not always translate into protection. The immune system, B cells and T cells, can quickly respond and offer protection even without detectable antibodies. So that is the answer as to why we do not routinely do immunity testing for yellow fever antibodies. Next slide. So when might a booster be needed? Although lifetime immunity is recognized in an immunocompetent person, there are individuals, number one is immunocompromised individual, for example, a person with HIV, that immunity may wane over time. If a child was vaccinated before the age of 2, that immunity may be in question if it is lifelong or not. And also people who have received concurrent MMR vaccine, as of the yellow fever. MMR, of course, is also a live virus vaccine that may translate to decreased or a less robust immune response. And 2 women vaccinated during pregnancy also may have less durable immunity. And also, we need to be mindful as we are recommending yellow fever vaccine, are the people that we are counseling going to areas that have a current outbreak in zones. And that would be another precaution. So are they going somewhere where there's current outbreaks and they'll be there for a while, and so they are at increased risk? Okay, next slide, please. Okay, so I have this little box for everyone, so you can kind of look back at that. A healthy adult immunocompromised has yellow fever vaccine after the age of 2 years. They are presumed to have lifetime immunity and no booster is needed, an immunocompetent person. Now, if they are going to a yellow fever outbreak area and it's more than 10 years post-vaccination, but they are doing some research, they're going to have high exposure, they might not have adequate ability to use all the insect precautions that we would recommend, they may be, you might consider having a yellow fever vaccine for this person. So I want you to hear that a lot of this decision making is on the clinician level. Now, I also want you to be very mindful if you have a situation like that, use the ISTM community. Put this in the discussion chat, and when you get to these harder decision making, let the travel health community help you with these. Now, if there was an infant or child where they received the vaccine less than 2 years old, they may require a booster as their response may not have been as robust. Immunocompromised again, and pregnancy, MMR co-administration, and also stem cell transplant recipients, that booster may also be considered at that time, assuming they had the yellow fever vaccine prior to 10 years. Oh, and the stem cell transplant. Okay, next slide, please. So we have a case study right now. We have this gentleman, he's 48-year-old male. He's traveling to Nigeria, which is an area of outbreak. He is an immunocompetent individual, no significant comorbidities, non-smoker, no allergies. He is going to West Africa for 2 weeks. He is going to leisure with visits to urban and rural areas, including wildlife and safari tours. Now, with this individual, even though he is immunocompetent, he did receive his first vaccine at 10 months of age. So this would be an individual, because he's going to an outbreak area, that would be considered to have that second dose of the yellow fever vaccine. And again, the second, next slide, please. So we have now a 54-year-old female. She's traveling to Brazil. She received a dose of yellow fever vaccine at age 25 in the second trimester of pregnancy. All her immunizations are up to date, the other ones. She has a medical history of hyperlipidemia, hypertension. She's on medications for both of those conditions, allergic to penicillin. So she is going to Rio for 1 week, and she's going to an Amazon River cruise for 2 weeks, so her stay is 3 weeks. This would be considered adventure travel, and there is an increased risk of yellow fever with her itinerary. She received that vaccine, yellow fever vaccine, during pregnancy, so she would also be a candidate. I would administer a second dose of yellow vaccine for this patient. So, and then the last slide, these are my references, and I thank you for joining us today for this webinar.
Thank you so much, Linda, for that presentation. So because we're a little bit on a time crunch, we'll just ask a few questions in the chat box. So the first one is, Dr. Schumacher, if you're able to answer this question, if a patient received yellow fever vaccination pre-transplant more than 10 years ago, can she be safely revaccinated since it would be a booster and not an initial dose?
So if the patient was immunized pre-transplant,
correct,
with yellow fever,
yes,
that was the question.
That is right.
The transplant, it's not the transplant, it's the medication since that becomes the issue. So she would have immunity to it, okay, from whatever happened pre-transplant. Being immunocompromised afterwards, yes, is not good, but it doesn't negate the immunizations from before, okay? So she would be, I mean, obviously much better off than she is right now. But no, one would, in the case of the transplant, where you're taking the immunosuppressing drugs, you would never be immunizing again with a live vaccine.
Thank you. Another question, sorry. There's actually quite a few questions in regards to live vaccines. Is there actually, if any of the panelists would like to answer this, for someone who has received a live vaccine less than 30 days prior to coming to see you to obtain yellow fever, if they are traveling to areas with active outbreaks or high risk, would you still give them the yellow fever vaccine? Would anyone like to answer that? So there's quite a few questions in regards to the time interval.
Dr. Schumacher, you're preparing to answer.
Generally, no. You want to stick to that pretty well. The trouble is you're screwing up the efficacy of the previously given vaccine during that time. Actually, for both vaccines, they're just not going to be as effective. Okay. Is it harmful? Like, will you have a greater increase of reaction? Not necessarily, but you're kind of going to invalidate some of the performance of both vaccines if you're not giving them on the same day.
So giving them simultaneously, I think, is the ticket if you can, and
if you
them by
can.
30 days if you have to, but
Yeah.
often that's not the case because of departure.
Yeah. And having said that, I will give a younger person multiple live vaccines at the same time and not think about it. Okay. So if you're a 25-year-old, you're going to get, or let's say a 35-year-old who needs a measles booster, I'll give them the measles booster. I'll give them the yellow fever booster, or I'll give them, yellow fever and chikungunya live vaccine, potentially at the same time. I would not do that for somebody over 60. I think generally for those people, you want to be very judicious and give one live vaccine, at a time, because you're going to avoid some of those serious complications.
Okay, thank you. Another question: for children who received the first dose at 9 months, what should the timing of the booster be? 10 years from the first dose? And where would those guidelines be? Sheila, would you like to answer that?
You're on mute, Sheila.
There we go. So the question is, they got their live vaccine under 10 months?
Yes. And when would their booster be, or if there should be one?
You could probably do it after the 10 years. I don't know what Dr. Schumacher would say, but um, I would probably go with that 10-year guidance that we used for many, many years, and then that would give them their lifetime immunity for the rest of their life.
Yeah,
Yeah, I
I would
think
agree. That whole list that Linda went through, where we might consider doing a vaccine again. So she got somebody who got it during pregnancy or, together with an MMR and they're going into a very hostile area. I think the 10-year mark would be, totally appropriate in those cases.
I agree. Yeah,
I would agree as well.
sounds good, Sheila.
Thank you. If the 8-month-old Sheila, this is from your case study, gets yellow fever vaccine, the mom also gets the vaccine. Does the mom really need to pump and dump?
No.
So 8 months old is getting it as well as the mom.
In theory, it would make sense that they wouldn't need to pump and dump because they both got the vaccine. But I don't have a reference to um, stand by that statement. But if they both got the vaccine, it would make sense that the reason that they would pump and dump is because the yellow fever vaccine would go through the best breast milk, and if the child didn't have it, that's what you're trying to protect. But if they both had it, technically, you wouldn't have to.
I would agree too. I guess we'll have time for one more question. We often see patients that are taking topical steroids or other similar medications. How do you handle this for those wanting to get yellow fever vaccine?
So let me start. So generally, topical steroids, not a problem. Inhaled steroids, not a problem. Okay. You are looking at, and we use prednisone as the equivalent. You've got to be taking 20 milligrams of prednisone a day, or the equivalent amount in dexamethasone or whatever it is. There's a scale that'll tell you for a period of time. Okay, like several, a week or two minimum to be considered immunosuppressed. Okay. Even some of the things that you think may be immunosuppressive. I'll give the example of Dupixent, okay, for asthma. That one is not considered immunosuppressing. But with steroids, the magic number is 20 milligrams a day. So even if somebody had a intra-articular injection of a steroid, if you wait a week, you are fine. Okay. But the topical stuff, generally no. And the inhaled stuff also not a problem either.
Perfect. Thank you so much. We do have lots of questions in the Q&A, which we'll put together in a handout, and it will be available on the website.
Great. Thanks, Tara. And thank you to all of our wonderful speakers today. With that, we'll conclude our program. Special thanks to everybody for hanging in there with us despite some of our technical difficulties. And again, also thanks to our sponsor, Sanofi, that helped provide this program, which all of the content was it was an unrestricted grant from Sanofi. And at the conclusion of this webinar, a survey link will be available in the contents of the tab and the program located in the learningistm.org. So please find it there, and you can see it on your dashboard once you've logged in. Take a moment to complete the brief survey, and your comments and suggestions are very important to us as we move forward and plan future events. For anyone claiming continuing professional development credits, the certificate can be downloaded on the contents tab in the program, and that's located also at the ISTM.org after the webinar and the survey is completed. So you have to do that survey in order to access it. You'll find the webinar page on your dashboard once you're logged in. Everyone joining us today receives access to the on-demand archive recording of this presentation, you will be notified by email when the recording is available to view. If you have any questions about today's webinar or have issues accessing the survey, let us know, and you can send an email to learning@istm.org. So this concludes our program. Again, thank you so much to all of our wonderful speakers, and we'll look forward to seeing you again at our next webinar.